This presentation is focused on the topic of environmental epidemiology, which is a really important component of our class. And hopefully by the end of this presentation, which has two parts, you'll feel more comfortable with terms and with calculations associated with epidemiology and how it's applied in environmental health. By the end of this presentation and your review of the chapter, you should be able to define the term environmental epidemiology. You should be able to provide examples of how we use epidemiology in environmental health, identify ways that we look at associations between environmental hazards and health outcomes, and examine different study designs we can use to examine how environmental factors influence health. Environmental epidemiology is a key field or discipline that we use as environmental health scientists to understand how diseases are distributed in populations and how exposures to environmental factors can contribute to those diseases. In most settings, environmental epidemiology examines exposures that are not chosen, that they're involuntary. When we think about how epidemiology contributes to environmental health, we can think about key components about how we examine the role of environmental health in populations, how we use observational data to examine environmental health factors and how they influence health, how we use epidemiology methods for study designs in environmental health, and then we can examine a couple of ways that studies are used to examine health factors, health outcomes, and environmental components. Environmental epidemiology typically uses a population and examines either illness or death with respect to an environmental exposure. And in this case, we might think about two components, the exposure and the outcome. The example of is lung cancer mortality higher in area with higher concentrations of what we consider smokestack industries is a question for environmental epidemiology. In this case, the outcome is lung cancer, and the exposure is industries that put pollutants into the air through smokestacks. Epidemiology uses observational data very often in environmental health. In most settings, we cannot intentionally expose people to harmful substances, and so we usually take advantage of naturally occurring situations to study the role of the environment in disease. When we think about the history of environmental epidemiology, it goes back as far as the 1700s, where a London surgeon named Sir Percival Pott was really the first individual thought to describe an environmental cause of cancer. And if you think back to our Module 1, where I talked about the role that occupational health had in informing environmental health, he again is an example of a physician. He was a surgeon who identified a large concentration of disease in a certain category of workers. And these were chimney sweeps. These were people that went into chimneys in London and had to clean them out so that they could continue to be used. And when they did that, they were exposed to really high concentrations of substances in the chimney, particularly in the middle of their body. And he noticed that these chimney sweeps had a high incidence of scrotal cancer because they contacted that soot so often. Of course, for anyone that's ever had a class on epidemiology, you've likely heard about another physician, an anesthesiologist named John Snow, and he is probably the father of epidemiology. But interestingly enough, the problem he was solving was an environmental problem. John Snow, among many things, used both spatial distribution of disease to help identify a water source as the source of cholera. There's a wonderful book about him and the way that he investigated this called The Ghost Map, and I'd like you to watch this video on TED Talks about the Ghost Map, which I'll also link to in our module. This is a map of cases that he put together, where you can see that each horizontal line, which makes a bar chart, is a case of cholera. And it's clear that the higher concentrations are associated near the Broad Street pump. Environmental epidemiology applications in environmental health typically include using tools from epidemiology to investigate environmental health and health outcomes. And the best way that we can do this is through study designs like cross-sectional, ecologic, case control, or cohort. For each of these study designs, it's important that you understand key factors that go into the study design and their advantages and limitations. In addition, when we classify epidemiologic studies, we can classify them in one of two ways. Descriptive studies, where we're just examining a description of disease according to certain conditions, maybe an environmental health exposure, and analytic, where we're attempting to understand the causal associations or using hypotheses to derive associations between exposures and health conditions. And in the course of this module, I'll ask you to review both types of study designs and differences between descriptive and analytic studies. As I mentioned, there are lots of designs used in environmental epidemiology, and I would like you to identify and describe each one of these. I will give you two examples from this list, but then I ask you to go further and read the textbook and also some of the articles that we've been assigned. So, a case control study is a very classic epidemiologic study design where cases of disease are sampled and exposure status is assessed after the fact that the disease has been identified. In addition, people that don't have the disease of interest are also sampled to identify their exposures. An example of a case control study would be the incidence of breast cancer in a population, defined by the study characteristics, and examined whether or not certain environmental exposures may be associated. An ecologic study design, on the other hand, examines exposures and outcomes on a geographic scale. So in this case, we might be interested in communities and their disease status and how they're associated with different environmental exposures. It's more difficult to understand the specifics of the associations with an ecologic study design. When we think about environmental epidemiology, we have to think about how we're defining the health outcomes. In cases of outcomes, we could be thinking everything from self-reported illness or symptoms to clinical symptoms to mortality or death. And it can be that broad. Each one of these has a different type of measurement and a different measurement validity depending on the topic of interest. Once we've identified our measure of interest for disease, be it self-reported respiratory illness or clinical diagnosis of pneumonia, we can then use measures of disease frequency, like prevalence or incidence, and measures of association, like incidence rate, to compare exposures of interest. In the next few slides, I'll present definitions of measures of disease frequency and also some examples of measures of association that we might consider in examining links to exposures of interest like environmental risk factors, air pollution, water pollution, and disease outcomes like respiratory illness or diarrhea. Prevalence refers to the number of existing cases of disease health condition or deaths in a population at some designated time. A point prevalence has a time designated very specifically, and it refers to all cases of disease, health condition, or death that exist at a particular point in time relative to a specific population from which the cases are derived. A good example of point prevalence might be in a 2-week survey of diarrheal disease in a community. We ask everyone who in the last 2 weeks has had diarrhea. That would be a point prevalence of diarrheal disease in that community. Incidence and incidence rate measure new disease cases, not existing, and that's a major difference between prevalence and incidence. How many new cases of disease happened over a certain time period in this population of interest? It can be deaths, or it could be new disease. New cases of influenza in a daycare center over the last 4 months would be an example of an incidence and an incidence rate. Case fatality rate is a measure of the lethality of the disease or the severity of the disease. And this is important because some diseases have a high risk for infection and illness, or sometimes just infection, but very few major health complications. We can think of other diseases that have a very high case fatality rate. And so, for example, Ebola has a high case fatality rate. I think 50 to 90% of people that are diagnosed with Ebola will die from the disease. That's probably a disease that has one of the highest case fatality rates that's currently circulating. Another disease that we have come close to eliminating but has seen a resurgence is yellow fever. Yellow fever case fatality rate is 30%. So 1 in 3 people that get yellow fever will die from it. Those are very high proportions of population that get the disease that die from it. Other diseases may have very low case fatality rates. So we think about measures of disease occurrence. We can think about measuring existing cases of disease, measuring new cases of disease, and looking at how many of those cases go on to have a severe outcome like death. When we want to start to understand how those diseases are associated with exposures important in the environment, we will use measure of association. And lots of different measures of association are available. I will introduce them briefly now, and we will go over some examples both online and in class that will enable you to understand them better. But I'd also ask you to rely on your training in epidemiology that you likely have had prior to this class or in the same time with this class to help you understand these. So the odds ratio is the measure of odds in favor of exposure among cases or outcomes to the odds in favor of exposure among non-cases or controls. Here's a 2x2 table for data from a case control study, which is commonly the data source for an odds ratio. And here you see how we can classify a 2x2 table with exposure status, yes, no, and disease status, yes, no. And A are all the people that were exposed and had disease. B are all the people that were exposed and did not have disease. C are all the people that were ill but not exposed. And D are all the people that were not ill and not exposed. And how we calculate an odds ratio is A times D over B times C. And in this case, an odds ratio greater than 1 suggests a positive association between the exposure and the disease or a health outcome. Relative risk is another measure of disease association, and it focuses on the risk of disease in an exposed group compared to the risk of disease in a non-exposed group. In this case, we might consider an incidence rate ratio or a risk ratio as measures. In a similar table, now for a cohort study, you can see disease status same. A is those with disease and exposed, and D is those without disease and unexposed. And the calculation of a relative risk is A over A plus B over C plus D. It's slightly different than an odds ratio. There are reasons for that are beyond the scope of what we will discuss in this class. But similar to an odds ratio, a relative risk greater than 1 indicates that the risk of disease is greater in the exposed group than in the non-exposed group, and under 1 indicates that the exposure might result in a possible protective effect. In most cases, for environmental exposures, we anticipate a relative risk greater than 1. But there are some examples where environmental exposures might be associated with protective effects of health. This could be access to green space in a community. This could be access to water filtration devices that produce a protective effect. There are other examples where environmental exposures, in this case, might be associated with protective effects, but it's usually not because a chemical or microbe is the result of the exposure. It's usually the reduction of hazardous agents that result in an environmentally protective effect.